Cataract is a universal problem. Every single person that lives long enough will develop cataracts. It happens at different rates in different patients, but cataracts are forming in every patient. When you are 40 years old, and the very first time that you have to hold something further away because you can't focus on it, that's the beginning of a cataract. And then it just progresses, usually gradually from there throughout your life. And then the lens is becoming more and more opaque and also more and more rigid and less flexible. But it's becoming more and more opaque until one day you reach a point that it's causing problems in your life. And that could be glare from headlights, that could be difficulty seeing the computer or being able to read. And the symptoms of cataracts are primarily related just to the opacification of that lens and then all of the fallout from that. Difficulty in any visual task. The one that usually brings patients to see the eye doctor is when they start to experience real trouble with driving at night. Cataracts scatter the light and therefore become very symptomatic. A person can come in here and have reasonably good corrected vision in a dark room with a well-lit, backlit target. Then we introduce glare into the equation and the vision drops off dramatically. And that actually creates an unsafe situation for driving at night. And that is one of the most frequently reported symptoms. You know, as we age, our eyes do change. And for some people, they could become more farsighted. Other people could become more nearsighted. And sometimes we see if a person has a rapidly developing cataract, they will undergo something called a myopic shift, which means they will suddenly start to become more and more nearsighted. So their distance vision, which used to be good, will now be bad. And because of the change in shape of the lens, they start to see a little bit better at near, but eventually just through progression of the cataract, they won't see good at distance or near. Which type of lens is a very important consideration and one that we like to spend a little time with our patients just to make sure we're making the right selection. So if a person has in their mind, I want the greatest range of vision, I really am motivated to not need readers for up close, then that is the multifocal. If they have a history of monovision, one eye distance, one eye near, and they've done well with that, that's always a good way to go. If someone has a lot of astigmatism, we might recommend the toric lens over another type of lens. And if a person has, for instance, a need to have their very best distance vision, let's say 20/20 or even 20/15, for a lot of patients, the light adjustable lens will give us our best chance at 20/20 or 20/15. I can't promise or guarantee any patient 20/20 or 20/15, but we're always shooting for that, and we have an excellent track record in this practice, and we pride ourselves on those outcomes. The studies from around the world show that the light adjustable lens does give patients in general twice the likelihood of a 20/20 uncorrected outcome. As far as the post-op recovery and that post-operative period, the post-operative adjustment, for monofocals, it's pretty straightforward and people generally have what they're going to have within a day or a couple days or a week. With a toric lens, it's pretty much the same. And so those recoveries are very, very straightforward. When we talk about a multifocal, there is a little bit of a period of neuroadaptation where the brain learns to access this vision. It's something analogous to when a person would get a new pair of glasses and try them on and they're different than their previous prescription. And sometimes it takes a little time for the brain to adjust to that. And we see that with the multifocals in that the reading vision really comes in when we perform surgery on the second eye. And then the patient's ability to translate from near to distance and back becomes more and more seamless over about the first month or two. The process of adjusting the light adjustable lens is pretty involved. It's pretty time consuming. It involves a fair number of visits here in this office, and we cannot begin the process of adjusting the lens until 3 weeks after the second eye. And that is based on the science of and the optics of lens implants, and the FDA studied the point at which they are stable enough inside the eye for us to then make permanent adjustments to the lens. So in general, the process for light adjustables, we begin the adjustment process 3 weeks after, and then we're going to see that person once a week for as few as 3 or as many as 5 weeks. And so it is a little bit time consuming before we get to the finished product. In our practice, we like to separate and offset the surgery between the two eyes, and that's generally the thought process in the United States. There are a few outliers that will do both eyes simultaneously, but just for safety reasons and to assure ourselves that everything is going properly with the first eye, we prefer to do them 1 to 2 weeks apart. And we make exceptions for that based on the clinical scenario. But generally we do the one eye first, and then whether it's 5 or 7 or 10 days later, we do the second eye.